Hi, and welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following on live, send us your questions or comments. You can do it on Twitter, just mention us at JAMA Network Open, or in the comment box on Facebook or YouTube. So our first paper today is the comparative effectiveness of different treatment pathways for opioid use disorder. And we have first author, Dr. Sarah Wakeman with us. Welcome, Dr. Wakeman.
Thank you. Thanks for having me.
Great. So tell us a little bit about yourself and why you did the study.
Sure. So I am an addiction medicine doctor. I practice in Massachusetts. I'm the medical director of the Mass General Hospital Substance Use Disorder Initiative. And I also practice in primary care and in our general hospital leading our addiction consult team. And so I spend my professional life, my clinical work, caring for people who suffer from substance use disorder. And predominantly alcohol and opioid use disorders are the most common types we see here. And clinically, I've long been a treatment provider as an addiction medicine physician, but one thing I've been struck by is that they're in the community, in terms of what clinical practice people have access to, there's often a lot of variability in terms of the types of treatment that people with opioid use disorder access or are able to access. And there haven't been many real world studies actually comparing the effectiveness of those different treatment pathways. And so this was a real gap in sort of the clinical work that I do, and an opportunity to try to answer that question.
Right. So tell us what you did here for this study.
Sure. So in this study, we use claims data of a nationally representative sample of adults who were commercially insured or had Medicare Advantage. And we identified a cohort that had opioid use disorder. And we tried to be quite specific in that, given some of the limitations in diagnosis code data about opioid use disorder. One thing that we've seen actually is that people are erroneously categorized as having what used to be called opioid dependence based on DSM-4 criteria, when in fact they have chronic pain on chronic opioid therapy. And so we tried to be quite thoughtful in how we constructed the cohort to be pretty sure that this patient population, in fact, did have opioid use disorder. And so we were able to identify a cohort of almost 41,000 adults. And then we classified them into 6 different treatment pathways, the first being no treatment, and then the 5 remaining being common treatment pathways that are used in treating people with opioid use disorder. So individual counseling, outpatient counseling, intensive outpatient counseling, which is multiple times a week, detox or medically supervised withdrawal or inpatient residential treatment, and then 2 different medication buckets, either medication treatment with buprenorphine or methadone, or medication treatment with naltrexone. And then we looked at associations with 2 clinical outcomes, overdose and then opioid-related acute care utilization, which we really used as a proxy for clinically significant recurrence of opioid use disorder. So those were inpatient hospitalizations or emergency department visits for an opioid-related cause.
Mm-hmm.
And just a quick question, how did you deal with, or was there a way for you to be able to deal with overlap in terms of treatment options? So I imagine that some patients may, have 2 or more of these treatment options available to them or are using them.
Yeah, great question. So we bucketed people based on the initial treatment they received after the diagnosis. So based on the claims data we had, it became clear that a person had an opioid use disorder. And we did our analysis essentially in an intent to treat approach, where people were in an exclusive treatment pathway based on that initial treatment. The interesting thing is we actually did some exploratory work that we didn't publish here, but as we were coming up with a study design to look at how much people move between treatments, and it actually wasn't as much as we thought, which I think is really interesting, that when you start into a certain treatment pathway, and there's lots of reasons about both the patient and their environment and what they have access to, I think that probably locks them into that treatment pathway. There wasn't as much movement between those pathways as we would have necessarily thought from the start.
Yeah, I'm going to welcome Beto Sanchez, who joined us, and Min Lakong. And not to spoil too much, but one of the papers we're going to talk about later in the show after you're gone is actually looking at what availability of medications for opioid use disorder in residential treatment facilities, and it's pretty low. 60% don't have any medication available. So it certainly seems plausible that once you're on one pathway, like that's the channel you're in for a while.
Mm-hmm.
Yeah, absolutely.
All right. I also, Fernando May-Diaz joined us as well. Welcome. We're talking about comparative effectiveness of different treatment pathways for opioid use disorder. I was just, I'm an ER doc. I know a bit about substance use disorder and opioid use disorder. I don't know a ton about the, longer term treatment. And I was just blown away just by the basic epi here, that 60% of people are just getting outpatient counseling. 1 in 20 people who was able to get, in your database diagnosed with opioid use disorder, which as a clinician it's hard to get that kind of diagnosis.
Yeah.
That's pretty rigorous. And 1 in 20 didn't get any treatment at all. So it's pretty interesting. 13% got bup or methadone, and then 16% got inpatient detox or residential services. So really interesting summary numbers.
Absolutely. I'm wondering if you could talk a little bit about the reasons, or the thoughts, just as being somebody that practices in this realm, if there were any thoughts as to why these discrepancies exist, or why potentially patients that are eligible or should receive some of the therapies are not maybe getting it. Is it just an access reason? Is it something is it provider facing? Is it a combination of both?
Yeah, so I think there's a lot of reasons for that. I think, sometimes we think about insurance and access. This was a commercially insured population. So that part, although some insurance companies do have barriers to medication treatment, for the most part, this is a population of patients that should have access to care, and yet still, as we saw, less than 13% were treated with what would be considered gold standard treatment. I think, there are many levels of barriers. One is outright stigma about the use of medications, and sometimes buried in that, and also separate from that, is really a misunderstanding about the role of medication treatments for opioid use disorder. I think there's still some confusion, both in the public and even for some providers, about the difference between physical dependence and addiction. So some of the kind of stigma-laden myths that I'll hear about medication is that you're just addicting someone to methadone, or that they're not sort of truly in recovery if they're still on a medication. And I think that really gets at this distinction, that someone who's taking a daily medication to be healthy, to function normally, to parent, to work, to not die from overdose, is not addicted to that medication any more than a patient with diabetes who needs insulin every day to be healthy and be normal is not addicted to their insulin. So I think that's one sort of misunderstanding. I think historically the addiction treatment system and addiction care has happened very separate from the rest of the medical treatment system. And it's only recently that we're seeing emergency room doctors, for example, and primary care doctors learning how to use these medications, being able to offer these medications to people with opioid use disorder. And so there's been a lack of that integration into the care system. And then we also have a lot of regulatory barriers that make it hard for providers to be able to offer these treatments, and make it really hard for patients to access them. So, this is a national study. We know that across the country there are essentially treatment deserts where, especially in rural counties, there may not be a single buprenorphine waivered physician in the entire county, and so patients may not have access to these treatments. And that kind of restriction on prescribing is very different than how we think about other medical treatments for other conditions. And then similarly with methadone, methadone really requires going to a tightly regulated opioid treatment program. Access to those might be limited depending on what part of the country people are in. And there's a lot of hurdles, a lot of barriers to get into care that may actually prevent people from accessing these treatments.
Mm-hmm. All right. Well, we're going to welcome Andrea Carvalho Mendonça, who has joined us. Sorry about the pronunciation. So perfect timing. So let's get down to the brass tacks. What did you find? What's the comparative effectiveness between the different pathways?
Yeah, so again, we're comparing these 6 treatment, or really 5 treatment and 1 no treatment pathway, comparing the effectiveness to no treatment. So each of those 5 pathways compared to no treatment on the outcomes of overdose and then opioid-related acute care utilization. And what we found was that only treatment with methadone and buprenorphine was associated with a reduction in overdose, a 76% reduction in overdose at 3 months and a 59% reduction in overdose at 12 months. And methadone and buprenorphine were also associated with a reduction in acute care utilization, both at 3 and 12 months.
Yeah, that's really interesting. I mean, it's obviously this is observational data, and the biggest potential confounding is where people put on are there differences that got people put on the different pathways. But just kind of reiterating or reinforcing the previous data we have that it's the medication therapy that works for opioid use disorder, and that's what you guys found in the study too here.
Yep.
Yeah. So what's next?
Yeah, I mean, I think there's a lot of changes that can happen both in the medical system, on the policy side, and there's always more research that needs to be done. One limitation, as you point out, this is an observational study. We tried to control for differences, but that's always a limit of observational data sets. I think the benefit is really the size, and yet even so, there was a very small percentage of patients treated with naltrexone. So I know that's one question that has come up when I've talked to people about this paper, and I think we do need larger real-world data sets to really understand outcomes of all treatments. And the other piece is that because this is claims data, we're looking at really the worst negative outcomes that we hope to prevent. But ultimately, the goal of treatment is really to improve the quality of people's lives in addition to helping them stay alive and out of the emergency room and hospital. And so further nuance about those really good positive clinical outcomes, I think, is needed. But mostly, I just hope that we continue to advance our approach to caring for people who use drugs and people with opioid use disorder, and that we begin to shift to a model where we make it easy for people to initiate treatment. We provide people with the best evidence to make decisions about their health care and what's right for them and their goals. And then we really focus on how do we keep people engaged in care rather than a system that really historically has made it very hard for people to stay in care.
Right. And along those lines, I really liked what you showed in figure 2, was that basically there was a dose-dependent success rate with the medication use, which again kind of reinforces that if you're on a pathway where it's working, the longer you're able to stay on that pathway, the more effective, it is, the least likely you are to have these bad outcomes of overdose or acute care use.
Yeah, exactly. And I often find myself thinking about the sort of cascades of care that we started talking about with HIV care, where, the first step is diagnosis and identifying people who have the illness. And then the next step is initiating treatment. But then really the hard work starts of how do you help people stay engaged in care? How do you make your medical system welcoming to people who haven't always been treated well in healthcare systems? And how do you keep them on life-saving treatment so that they can stay in remission?
Right.
Yeah. I'm actually just wondering if you were, again, as somebody that practices in this realm, if you were surprised by these results, or if this sort of confirmed for you something that you, intuitively felt made sense, or potentially kind of goes along with other concurrent studies.
Yeah, I guess I wasn't surprised. I think this really builds off what we've seen in clinical trials of medication treatment. So it really confirmed for me what we've seen in non-observational study designs, that these medications are beneficial. I think, I was a little surprised by the lack of association of some of the other treatment pathways, that only methadone or buprenorphine showed an association with reductions in these outcomes. But it definitely reinforced the notion that everyone should have access to these meds. They may not be a patient's preference to be on medication, but they need to be able to have an informed discussion about the risks and benefits and really be able to initiate treatment if it's right for them and as soon as they show up.
Yeah.
Absolutely. Well, great. Well, this is a really interesting study. Again, I think you've done a great job of explaining it on Twitter as well. And thanks for joining us today to talk about it.
Great. Thank you guys for having me.
Great. Thanks. Take care. All right, so moving on, we're going to welcome Alreem and Ines, who just joined us. So we're on the table of contents rundown, and first paper we have is the association of parental and contextual stressors with child screen exposure and child screen exposure combined with feeding. Basically, what they were looking at in this study was they looked at about 1,000 kids from a primary care research network in Toronto from 7 to 18 months of age in 2011, 2018, and trying to basically see if measures of the kid's stress, the parent's stress, correlated with how much screen exposure they had overall and how much screen exposure they had at meal or snack time. So they used some interesting tools. They used the negative affectivity subscale from the infant behavior questionnaire, which I guess is how you assess child stress in an 18-month-year-old or younger. There's a parenting stress index that's a similar 36 question short form, and basically, and then assessed measures that there's how much screen time the kids had overall and how much screen time with meals. Kind of some bottom line numbers. 75% of the kids had some level of screen time, an average about an hour a day or a little more. About 37% had screen time with feeding, which was an average of about 4.4. 4.4 meals or snacks a week with screen time. So that's about one every other day, a little more than one every other day, which actually is probably less than I would have expected.
That's true.
So that's good. And basically, not surprisingly, there were positive associations. Kids and adults with more stressors were more likely to have screen time and screen time with meals. And then when they looked at the sociodemographics, other sorts of covariates, lower household income was associated with an increasing amount of childhood screen exposure, and with lower income with more screen exposure with feeding, which can make all sorts of guesses about why there are associations there. I don't think anyone would expect that this screen time is causing low income.
Right.
But it certainly makes sense if you're more stressed, if you have less income, less time, less resources for childcare and things like that. As my wife has always joked, especially when our daughter was young, people say don't use a screen as a babysitter, and she's like, why else would you use a screen? That's the whole point.
Yeah. No, I felt like, especially as a parent, this kind of resonated with me because it is pretty stressful. Like, childcare can be really stressful. And so I can understand, using child screen time to sort of help with some of these daily activities. Yep. So I thought it was I thought it was very interesting from that perspective. I guess the next sort of step would be to think about, like, how can we as a society try to alleviate some of those things. And I think from this study, the stressors, they weren't necessarily quantified in terms of what was causing it. So certainly
like the overall
exactly.
Yeah.
So having a child can be stressful too. Sure. So in certain situations,
get a positive feedback.
Yeah, exactly.
Yeah.
Exactly. So like things to work on, I guess, or
to
think about.
Right, and certainly something that's we've had, not to make too light of it, but as a parent, you get stressed out about your kid having too much screen time.
Yes.
So then that itself is a stressor.
Yes, that's very true.
It's tough. Although I've been surprised how easy it's been when we've decided, she's had too much screen time, we're just going to stop. Or our daughter used to watch like a TV show every day in the morning because mornings are hard.
Yeah.
And then we just said, no more on school days.
Yeah.
And it was hard one day, and then after that it was fine. That's just the way it was.
Yeah, no, exactly. Routine.
Jumping back a little bit, we got a question from John Peterson on YouTube who asked about if naltrexone or the brand name Vivitrol was not associated with positive outcome. And John, that's correct. In this study, there was basically no association between naltrexone and any difference from no treatment. Obviously not recommending that people stop naltrexone or anything like that based on this. Again, this is observational, and there's a lot of patient selection about who gets what, and how patients done, and all sorts of other artifacts and stuff. But yeah, it's overall, naltrexone was not associated with lower rates of overdose or lower rates of acute care use, so going to the emergency department or being hospitalized.
Did we talk maybe a couple months ago about inhalational? It was something.
That was naloxone.
Yeah. Oh, it was naloxone. Yeah.
That was naloxone.
Okay,
intranasal or intramuscular.
Yes. That's right. That's right.
And actually, since we talked about it, there were some interesting comments. I think a couple interesting comments online about how basically the absolute doses were the same, intramuscular or intranasal, but there's some of the pharmacology on it where it's effectively a lower intranasal dose, which makes sense.
That makes sense.
And as somebody who sometimes gives people intranasal naloxone, it's easier for me to just keep giving more in my setting. So I've got nurses who have access to our Omnicell to keep giving more and more. So, and it works.
Sounds good.
And eventually, it always wakes people up, basically. And if it's a high dose, it's either one of those newfangled fentanyl analogs, or it wasn't an opioid in the first place.
Oh, there you go.
All right, so what's next?
All right, so this is Trends in Healthcare-Associated Infection Prevention Practices in U.S. Veterans Affairs Hospitals from 2005 to 2017. I have to say, when I was looking at it this morning, and one of the co-authors is a friend of mine, so I was excited for that, Payal Patel.
Okay,
a little shout out to her for great work.
Very nice.
So the objective of this study was sort of the background, actually, to take a step back, is that the VA is sort of one of these places that's been an early adopter of certain infection prevention sort of bundles and policies. And so this study was trying to evaluate changes over time in IP practices and the perception of the importance of IP practices in VA hospitals across the country. And so they actually surveyed infection preventionists every 4 years, from 2005 to 2017. At VA hospitals. They had response rates from between 59% to 80%. They found that they looked at 12 different IP practices. In general, over time, they've seen sort of an increase in reported use of these, but there are some areas for improvement. So, and Figure 1, I believe, shows some of this. So in general, CLABSI, so catheter-associated line bloodstream infections, and C. diff infection, if I'm remembering this correctly, did show some improvement. But CAUTI, so catheter-associated UTI practices, certain ventilator-associated pneumonia practices, and diagnostic stewardship practices all were sort of lagging behind. So essentially said, we definitely have seen great strides, but there's also places that have been lagging and areas for improvement. And the one thing overall, which I kind of appreciated too, is that antibiotic stewardship was pretty high, actually.
Yeah.
97% in across the VA. So they having a program in place. So that's pretty remarkable and very heartening, I guess I would say.
Right, and you can see that at the bottom of the bottom of Figure 1D, the antibiotic stewardship has just jumped up in 2017.
So I think people are recognizing this is
Right.
really important, and it's nice to see that it's being implemented increasingly.
Yeah,
at least across the VA.
Yeah, absolutely. It was interesting to me. A lot of these are things that have gotten a lot of attention, especially over kind of the time course of your career and my career. Things like CAUDE and CLABSI, and C. diff, VAP. What they're talking to, I had to look into this, what they meant for the diagnostic stewardship. What was really interesting, but basically like the pop-ups that we have in our HR, like you ordered a C. diff test. Are you sure they had this much diarrhea over this many days? Or there was a test yesterday. Do you really need it today? And similar with urine tests. I think there's been this battle because, we need to try to prevent catheter-associated UTIs. Having a UTI diagnosed in the hospital, which is assumed to be a hospital-associated infection, it has been a quality marker. So a lot of places are kind of, or there's at least I've heard stories about hospitals just sending routine urinalyses to make sure that patients, they documented they had the infection before they came upstairs or whatever it was. So,
I used to do some infection prevention, and it definitely all of these things come up, and it's so true that I think now there's sort of this new term of diagnostic stewardship, something that we're thinking about, because just because we have certain tests doesn't mean that we always need to be ordering them, or if we're ordering them, we need to think about kind of how how do we interpret the results exactly. So all things to continue to work on, I guess.
Yeah, absolutely. Going to welcome a couple new joiners. Alexei Fedotov, Beo Beathach has joined us again. Mehmet Saraf, Akash Desai, and Miozala Beg. Apologies again if I'm mispronouncing anything. Feel free to chime in with how I can do better. One of the other things that's really interesting to me too, especially looking at like Figure 1C, the VAP prevention techniques, is some of these are things that are good beyond just infection prevention. Things like sedation, vacations, early mobilization, semi-recumbent positioning as opposed to being totally flat. Also, I am really interested in getting some silver-coated endotracheal tubes. Those sound fancy.
Yeah, they do.
and also Adelson Fortunato has joined. So next up, this is the paper I mentioned earlier. There's differences in availability and use of medication for opioid use disorder in residential treatment settings in the U.S. So they looked at nearly 3,000 residential treatment facilities that primarily treat opioid use disorder. And basically, only 30% gave long-acting naltrexone, only 1/3 would give buprenorphine, and only 2% give methadone, which is really interesting.
Really interesting, yeah.
Although, long term, I think it makes a lot of sense that we're moving away from methadone and towards buprenorphine. But buprenorphine is not for everybody. But still, I think this is less a sign of a trend and more of just a cross-section of where things are for this. But 60% of residential treatment facilities for opioid use disorder don't have any medication for opioid use disorder, and to me that's kind of bonkers. Again, this is out of my field, but knowing what we know about what's effective for opioid use disorder, that seems like a big room for improvement. They also looked at things like prescribing restrictions and the Medicaid expansion, and I was a little surprised they didn't find any frank differences with the Medicaid expansion.
I know, I agree.
And there's a figure 2 that shows some of this. The difference between states that expanded or didn't expand Medicaid. There's really just kind of trivial differences between the columns. But they did find when they looked at states, there's a figure in the paper that we don't have here, that when states that have more prescribing restrictions, so things like prior authorization or other things that you need to do to prescribe, in addition, of course, to X waivers, there's not surprising more or less prescribing when there's more restrictions.
Yeah, absolutely. I kind of think that also, I think it's kind of what you're saying, but I think it also sort of just points to the fact that there are provider-facing issues here, potentially, along with a whole host of other issues that may be, playing a role in this. And so it's not just potentially having access, but also, the people, other things in the...
Yeah. But again, I mean, there's a lot of negative stuff here overall and in this area. But anyway, we talked about, again, it's just been in the last, handful of years, seeing how much the pendulum has swung has been nice. So, again, we're getting everybody, like all the ER docs in my place are getting X-waivered. Lots of things that have changed. We're seeing a lot of dropping of restrictions and things like that at statewide levels. So
that's great.
So there are, lights at the end of this tunnel somewhere.
Optimism.
Right. All right. What's next?
All right. So this is association between adverse childhood experiences and dementia in older Japanese adults. So the background to this paper was that the prevalence of dementia in Japan has actually been increasing. And so the investigators wanted to look at the association between childhood experiences, adverse childhood experiences, and dementia, specifically among Japanese adults that were born before 1948 and were sort of present during the period of World War II, essentially. So they had 17,000 participants. They found actually, and they had kind of a ranking scale of how many adverse childhood experiences each sort of participant were self-reporting. They found that actually 63% of the adults that they surveyed did not have any adverse childhood experiences, or they didn't report it. So, that is potentially an issue. But that only 2% had 3 or more childhood adverse experiences. But of those 2%, those individuals actually had a greater risk of developing dementia, so which I think makes intuitive sense. More difficult situations as a child certainly may play a role in cognitive impairment later on.
And also just how I'm curious, and the total speculation, just is this something where, you have to spend some part of your mental capacity, processing or thinking about or dealing with your whole life, and people who don't have those adverse experiences don't have to, expend that effort, basically.
Yeah, absolutely.
But yeah, it's really interesting. I think the whole idea that, not just the exposure to World War II in this population, but also they note that Japan has a generally very, some of the highest longevity in the world. So it again gives a really interesting sample here. And also just, especially with the exposure to World War II here, that there's really high rates of parental loss in this subset. There was a commenter, I forget who it was, who noted that they may not have included sexual abuse in their adverse childhood experiences. It's hard for me to tell.
Okay.
But it's interesting.
I think it's always difficult too when you're looking at studies like this because people don't necessarily want to offer up that information. So it's tricky, but it still gives us at least a little bit of a snapshot into kind of what's going on.
Yep, absolutely. I'm going to welcome Jason Allen and Michael O'Brien. Welcome. We're on the last of our table of contents rundown papers. What do we got?
Yeah, so this is a research letter, Trends in Racial and Ethnic Diversity in Internal Medicine Subspecialty Fellowships from 2006 to 2018. This was a cross-sectional study that used GME census report data from 2006, to study race and ethnicity. From 2006 to 2018, I should say. So included were almost 300,000 internal medicine residents and 124,000 subspecialty fellows. They found that over time, the percentage of underrepresented in medicine minorities was essentially unchanged in internal medicine, although it was increased in fellowships, but that this was actually different by subspecialty. So notably, at least notably for me, the highest percentage of underrepresented minorities in medicine over time was in infectious disease. The lowest was in hematology oncology. You can see this in Figure A and Figure C. Overall, all of the sort of specialties that this study looked at had a lower percentage of underrepresented minorities than reflected in the general U.S. population. So in certain respects, making some progress, in others, maybe still some progress to be made.
Yeah, and we've got two parts to the figure here. So the first part, A, kind of shows the curve. The top line is the overall rates of UIMs as in internal medicine residents, and you can see the gap has definitely tightened a lot. So the fellowships are more representative of what's in the internal medicine residencies, which I guess overall is good.
Yeah.
But then if you look at figure C, or the figure part C, basically the big outlier on the far left side is the U.S. population, and all the much smaller columns are the individual fellowships and internal medicine residency as a whole. And you can see there's just a huge gaps that that need to be improved upon.
Yeah. One thing I was trying to find in here was if you look at Figure A, it seems like, from 2006, 2012, there we see kind of this steady increase, and then it kind of plateaus out.
Yeah.
And I wasn't sure if reporting had changed or if something, what had happened with that.
Yeah, I feel like I have some vague memory of ACGME changing how they ask some of these questions at some point, but that's not from reading this paper. That's just from like general offense, so I might be way off. But that also, that seems like a weird jump right then.
Yeah.
The one thing I noticed that was interesting to me too is that the lowest percentage of the UIM fellows were also the largest fellowships overall, which is kind of interesting because usually you see a regression to the mean. The largest,
right.
And also the more procedural specialties. I'm curious if there's cultural things. A lot of I'd say. I'm going to make broad generalizations, so don't hate me. But that more, in medicine overall, more procedural, more surgical places tend to be more traditional in all the air quotes way of that term. And there are stereotypes there, and they say something where it raises questions about possible factors that may be affecting career choice for UIM residents. Although to me, choice is always difficult because it's kind of like we talk about women in STEM or less high-paying fields, or things like that. Where is it really a choice to not go into a field that is more discriminatory or less representative?
Right. Well, that's the thing, right? I mean, if you see others doing that specialty, or if you have mentors, etc., you may be more or less likely to want to pursue that. So there's a lot of different factors at play here.
Right. Exactly. So going to welcome Esmita Tirano, who's joined us. I just got a couple little quick hits, which started doing recently, and hopefully we'll stay quick. First, a paper which includes author Preeti Malani, friend of the journal. But basically, it was a big survey. They asked a bunch of adults about how they feel about the kind of future with health insurance and health affordability. 45% of American adults had low confidence in being able to afford health insurance during retirement. Of these, they were more likely to avoid medical care and medications, about 18% overall, who specifically said they were avoiding some sort of medical care. And overall, 2/3 were concerned about potential changes to health insurance associated with changes in federal policies. I couldn't tell exactly how the question was pretty broad about changes in federal policies. The authors were pointing more to things like last year's attempt to repeal the Affordable Care Act.
Right. Was this over a specific time period, or?
I think this was a single time point in survey life. I want to say 2018. I don't remember.
Okay.
But, it's in the paper somewhere. Sorry. Another paper, machine learning model that can be used to predict in-hospital mortality of adults at time of admission with an area under the receiver operating curve of 0.84 to 0.89. This is one of those things like, seems helpful. I don't know. But also, most people who go in the hospital don't die. So how much of that is if you just predict no one's going to die, you'll be pretty accurate there. That makes up a lot of your ROC. But it might be useful in things like resource utilization, or eventually down the road, things like machine learning might be more helpful in helping things like, predict who's going to decompensate, might benefit from extra resources, things like that. I don't know.
It's sort of interesting. I feel like we're seeing more and more of these machine learning models come into play, and particularly in medicine. So it'll be kind of interesting to see kind of where that goes, how the models sort of continue to improve potentially too.
Yeah, and I'm really glad you said that, because that's not only interesting, but I needed to make sure you do. Study where they put RFID trackers on members of the medical team, so the attending, the senior residents, the interns, and the nurses, and tracked where they were and what they were doing. Just kind of not for ulterior purposes. But basically they split it up whether they're in the patient room, the workroom, or the hallway. And not only did the docs spend more time in the workroom versus the patient room, about 260 minutes versus 35 minutes for the residents, and about 200 minutes versus 30 minutes for the attendings. But they spent more time in the hallways than in the patient rooms.
Oh, no.
Which is really sad.
Well, so that makes me think a little bit about, just from a medical education standpoint, there's a trend, at least with certain attendings I've seen anecdotally, that some people actually like to do bedside rounds compared to hallway rounds. So, because the majority of your time ends up actually being the rounding, making the plan, at least in a training environment. And so that may just reflect the fact that a lot of people like to do the rounds in the hallway, which is... it's sort of interesting. I mean, people have different philosophies on this, and I can kind of see both ways. But
and there's all sorts of data about how we end up spending more time in the EHR than say in clinic talking to patients. I actually think a lot of that's not the EHR stuff, but the whether you're in the workroom versus the patient room, like yes, we need to spend time with the patients, and yes, a lot of it's the history and the physical and the therapeutic relationship and things like that. But also a lot of our work is arranging patients' care.
That's true.
And coordinating or that sort of stuff. So I don't know. We do need to spend time doing work, and that's what the workroom is for.
I'd be interested to see what the participants, when they saw the results of this, what they thought about it, just after having been followed around for a while.
Yeah, I will say I remember when I was in attending when I first my phone first started being able to do a step tracker, and it made me. I looked at the numbers and started thinking about how much time I spent at the computer at work.
Oh no.
All right. Well, that's all we've got for today. Thank you for joining us. Join us, of course, next week, Tuesday, 3 p.m. Central Time. These papers are all available at JAMA.networkopen.com, where everything's free and open access. And, of course, our new releases are coming out tomorrow and Friday, every Wednesday and Friday, 10 a.m. Central Time. Follow us on all the usual social media channels. And take care.
Bye, guys.